You're listening to This Week in Cardiology from theheart.org, Medscape Cardiology. This podcast is intended for healthcare professionals only. Any views expressed are the presenter's own and do not necessarily reflect the views of WebMD or Medscape.
Hi everyone, this is John Mandrola from theheart.org, Medscape Cardiology, and this is This Week in Cardiology for July 18th, 2025. This week, Finerenone. What not to consider when choosing the treatment of patients with AS, brain health after AF ablation procedures, early rhythm control of atrial fibrillation, and Watchman reimbursement cuts. First up, though, is listener feedback. I received an email from an academic EP doctor who's involved with regulation, and he wrote regarding my coverage of PE devices 2 shows back. He wanted to clarify my thoughts on the 510K approval pathway where devices get approved by being similar to an already approved device. I called this extremely problematic and called for the FDA to reform the 510 pathway. But my colleague writes that it's not up to FDA to reform the program. He writes the 510K pathway and the rules around substantial equivalence are in federal law and Congress would need to change these rules, so he suggested writing our congressman. And then added, speaking of the 510K pathway, he agrees it can be problematic but works well for devices like blood pressure cuffs and diagnostic catheters in which the underlying technology is well established, but it's much harder in things like AI or machine learning based devices or anything that is sort of but not completely new. He said that we spend a lot of time on these and often focus on whether the intended use is the same, whether we have enough bench and clinical data. And, quote, substantial equivalence means we need to be assured that the device performs as well as the predicate, and that often requires clinical data. So, as it is so often the case, listener feedback really teaches me a lot. I really appreciate it. I did not know, for instance, that Congress had to change the 510K pathway, not the FDA. So keep coming with the listener feedback. We all learn a lot from it. All right, next topic is Finerenone. Now, Medscape News has a good summary of the FDA approval of Finerenone. It's actually not an approval, but an expansion of the indication of the nonsteroidal mineralocorticoid receptor antagonist. The FDA initially approved Finerenone in 2021 to reduce the risk of cardiovascular death, heart failure hospitalizations, MI, and kidney complications in adults with CKD that was associated with type 2 diabetes. This was a rather specific indication. The new expansion will be for patients with heart failure and left ventricular ejection fraction of at least 40%, and that's a much broader indication. And this is based on the Fine Arts heart failure trial published in New England Journal of Medicine in 2024. Fine Arts was a big 6,000 plus patient trial comparing Finerenone to placebo in patients with HFpEF. These were 72-year-old patients, EF mean 53%, most with New York Heart Association Class 2, some with Class 3 heart failure. The primary endpoint of Fine Arts was a composite of total worsening heart failure events, and that could be a heart failure hospitalization or urgent visit and CV death. The follow-up was 2.5 years, and there was a 16% reduction in the primary endpoint. The hazard ratio 0.84 and the confidence intervals were significant. The absolute risk reduction was 2.8% or an NNT of 35. The primary composite was driven almost completely by heart failure events as there was no statistical differences in CV death or all-cause death. And this came at the cost of more increases in creatinine and potassium. High potassium more than 6 was 3.0 versus 1.4%. In Fine Arts HF is a fine trial. It was a positive trial. My criticism of the trial and Finerenone use in HFpEF centers on 3 main issues. First, the wrong comparator issue. Finerenone should have had to beat spironolactone. I say that because the Americas part of the TopCat trial, spironolactone versus placebo in HFpEF, clearly show that spironolactone improved outcomes in patients with HFpEF. And then, of course it does, right? Mineralocorticoid receptor antagonists, as a class, help patients in HFrEF and likely do in HFpEF as well. So, The question facing clinicians when they treat patients with HFpEF is which MRA to start, one that costs pennies, spironolactone, or one that will surely cost bunches, which would be finerenone. The lack of a head-to-head comparison between the two MRAs is what we get when we let industry control regulatory trials. If I were a person controlling these trials, and say I was at FDA, I would have pushed for a spironolactone arm in the fine arts trial. The second issue that I have with fine arts and finerenone is that the benefit was modest. Despite enrolling more than 6,000 patients, there were only 200 fewer events in the finerenone arm, and there was no difference seen in cardiovascular death. A 16% reduction in the primary endpoint was driven solely by heart failure events, not mortality. Finerenone is a diuretic after all. HFrEF patients have 4 classes of disease-modifying drugs, and we cannot call finerenone a disease-modifying drug in HFpEF. The third issue I have with fine arts is that the authors surely have, but don't share the effect on total hospitalizations. As I have discussed here and shown that in other HFpEF trials, most hospitalizations in these patients is not for heart failure. So, if a drug or device reduces one type of hospitalizations, here heart failure hospitalizations, but this type of hospitalization is only a small fraction of the total burden of hospitalizations, then the patient does not win. Heart failure hospitalizations are a reasonable surrogate in patients with HFrEF because in those patients, a weak LV is the primary health issue that they have. But in HFpEF, these patients are older and they have a burden with much higher comorbidities. So heart failure hospitalization becomes a much weaker surrogate marker in patients with HFpEF. Now, I don't have a problem with FDA approving the drug for this indication based on fine arts, but they should have been stronger in their regulatory input regarding the seminal trial. Industry isn't necessarily nefarious. They're just going to jump over the bar that we set for them. We help them when we set a low bar, and we make it harder on clinicians when we don't have a higher regulatory bar. Now, for the clinicians making this decision, we're going to have to see what the cost of finerenone is. I still believe we start with spironolactone and we keep finerenone in the bullpen for relief when the first line fails. All right, next topic is choosing TAVI or surgical AVR. Now, one of the most common decisions in the field of valvular heart disease is whether to do a TAVI or SAVR in a patient with severe aortic stenosis. Now, there are obvious cases when patients are clearly poor surgical candidates. TAVI is the best choice. There are also obvious surgical choices when the patient is very young or there's a need for concomitant surgical procedures such as LA ablation for AFib or mitral valve repair or coronary disease requiring revascularization. Then SAVR is clearly the best. But for the large number of patients in the middle, patients and doctors have to translate the nuances of the evidence, and that includes partner trials, Evolute, Notion 1 and 2, Dedicate, and UK TAVI trials. It's a lot of data. I mean, you could have day-long conferences on sorting through the details of these trials. And ultimately, I think there is a tension between the much lower burden of TAVI versus the long-term durability relative to SAVR. Now, the editors of the European Heart Journal and authors, mostly from New York, tempt us to consider another factor in the decision, and that is the carbon footprint of these two procedures. And I kid you not, the European Journal has the top impact factor of all cardiology journals, and it has now published a comparison of the carbon footprint of 10 patients who had SAVRs and 20 patients who had TAVIs, 10 in the OR and 10 in the cath lab. The authors used a model that measured the kilograms of CO2 equivalents based on the primary data such as the materials, procedures, energies in the preoperative, operative, and postoperative setting. The main result was that TAVI used less CO2 equivalents than SAVR, about half less. The numbers, not that they mean anything to me, is 300 kilograms of CO2 equivalents in TAVI versus about 600 kilograms of CO2 equivalents in SAVR. The postoperative intensive care unit and floor care accounted for the largest portion of the carbon footprint, And the intraoperative footprint of SAVR was driven by biological waste, postoperative length of stay, and inhaled anesthetic gases. And the authors conclude the carbon footprint of SAVR is about twice as high as those from OR TAVI or cath TAVI. These findings should potentially be considered when making population-level decisions and guidelines moving into the future. And my comments. I don't know what is happening to us as a field. The authors write this in the discussion, quote, while carbon emissions should not be the deciding factor in the treatment strategy for individual patients, relative emissions should play a role in the future when deciding between different treatment options. Now, I did a simple Google search on carbon emissions because I don't know the first thing about it. And even if we accept the author's calculations, the difference was about 300 kilograms of CO2 equivalents. Now, to fly across the U.S. is 1,000 kilograms of CO2 equivalents per passenger. So if you take your family of 4, that's 13x more than the difference in these two procedures. And I ask you to walk through Atlanta, Dulles, Newark, LAX, and just eyeball the number of people flying. I am all for climate stewardship. I ride a bike to work. I live close to everything in my city. I don't litter. I like European hotels that minimize wasteful energy use. But my friends, the role of carbon footprint should have exactly zero influence on medical decisions such as TAVI versus SAVR. Number one, it is minuscule relative to other human activities. And number two, we take care of patients, not the environment. Public health should have no bearing on individual patient decisions. And finally, I used to think that coffee, blueberry, and quinoa studies were the most wasteful of time and effort in a research enterprise. Now I think studying the carbon footprint of 2 medical procedures may have earned top honors in the most useless and wasteful studies. Come on, you all, stop doing this. All right, next topic is brain lesions and visual migraines after left-sided procedures. The group of Dr. Greg Marcus at UCSF continue to do interesting work in EP. Their latest, led by fellow Adi Elias, investigated the possible association of transeptal puncture during catheter ablation for ventricular arrhythmias with post-procedural visual auras. They also wanted to assess the relationship between occipital and parietal lobe acute brain emboli and migraine-related visual auras. These questions are important because it goes to the health of the brain during left-sided procedures, left-sided ablation, for instance. Now, left-sided ablations are undergoing a massive increase due to the use of PFA in the left atrium for ablation of AFib, so it's an important topic. Now, this work that was done is actually an observational sub-study of a recent RCT called the TRAVERSE trial. I'm going to discuss both because both papers are making the rounds in the EP world, but note also that this isn't just an EP topic because visual auras and microemboli in the brain also occur with any left-sided procedures such as coronary angio, PCI, and valvular procedures. Okay, so let's first talk about the TRAVERSE trial. This was published in Circulation this year in February. First authors, Greg Marcus. TRAVERSE randomized only 146 patients who were to have a left-sided VT ablation to either retrograde aortic approach versus transeptal approach to the LV. The primary endpoint was an acute brain lesion on MRI. The main result in the retrograde aortic approach, 28 of 62 or 45% of patients exhibited an acute brain lesion compared with 19 of the 69, 28% of those randomized to a transeptal puncture, and that p-value was 0.036. The authors of TRAVERSE found no differences in clinically manifest complications or procedural efficacy, and no patient had a clinical stroke. Notable in this study was that 10% of patients did not get the MRI, which means that they did not have a primary endpoint measured. And the authors made 3 big conclusions from the data. One is that they said a transeptal approach may be the more favored strategy over retrograde aortic for catheter ablation of VT in an effort to reduce brain injury. The second conclusion, the heightened risk of new brain lesions detected using MRI without overt clinical manifestations in the retrograde aortic arm may suggest a higher risk of other organ damage that is not immediately clinically occult. And third, It is possible that procedures conventionally performed through a retrograde aortic approach might incur similar harms, and that novel transeptal approaches may yet prove beneficial. Okay, my comments. The first thing to say is that I think they have convinced many in the EP world that transeptal is the preferred approach to the LV. I sent a message to our private EP group, message group about access for a VT case that I was doing, and the overwhelming answer was transeptal approach, and quote, I am impressed by the UCSF data, end quote. Well, my friends, I like and I respect many of the authors of this multi-center trial, but this trial is a mess, and it does not tell us the best approach to the LV. The first thing to say is that there were only 47 primary outcome events, and the primary outcome events were white spots on an MRI that disappear and have no known permanent sequelae. So even if there was a statistically robust difference, would it be clinically significant? I'm not sure, and likely neither are you. I put the numbers into a fragility index calculator, which tells us how many non-events or events in each group would have been required to make the results non-significant or greater than a p-value of 0.05. The fragility index of the TRAVERSE trial is 1. If one more patient in the transeptal arm had had a white spot, then the trial is non-significant. This is not a statistically robust finding, not at all. What's even worse is that 10% of patients did not have an MRI, so the missing data is 10x the fragility index. Now, the authors acknowledge this limitation, but they kind of soft roll it in a discussion. The academic editorialists don't mention the fragility of the data, nor do they mention the massive missingness in this trial. I think this is an existential problem with the study. We simply do not know. Imagine a drug or device outcome trial where 10% of the patients did not have a primary outcome measured. My final thing to say about this study is that EP doctors might spend less time destroying the left atrium during AF ablation and more time learning to look at evidence. TRAVERSE was a good effort. It's an important study question. But the internal validity issues, the small differences in surrogate outcomes, and no difference in stroke tells us near zero about what approach to use when ablating LV sources of arrhythmia. To me, the doctor should choose the approach most likely to achieve success. Retrograde aortic access is clearly superior to transeptal for some areas of the V. TRAVERSE should not discourage them from using it. In the meantime, the question of the best approach is an answerable question. It simply requires a larger study with more primary outcome events and less loss to follow-up. All right, part 2 is brain lesions and visual auras. The second paper, the first author, Adi Elias, was published in Heart Rhythm last week. This observational study asked 2 important questions. A, did the access site, retrograde aortic or transeptal, affect visual auras? And B, was there an association between occipital and parietal lobe white spots and migraine-related visual auras? In total, 121 patients of the total of the 146 had assessment for visual auras. 18 reported a visual aura in the first month after the procedure, and 103 did not. Now pause there, because the authors will soon be making conclusions about 18 reported visual auras. Now this paper also suffers from serious missingness, as 15% of those in the transeptal arm and 21% of those in the retrograde aortic arm did not complete the 1-month questionnaire about having a visual aura, which was the primary endpoint of this observational study. The first main result was that there was no difference between post-ablation visual auras observed between transeptals and retrograde aortic approaches. It was 16% versus 14%. The second main result of this paper was that more participants with acute brain emboli in the occipital or parietal lobes experienced migraine-related visual auras. It was 38% versus 11%, and that p-value calculated to 0.014. Now, the actual numbers are 7 of 18 of those with occipital or parietal lesions versus 12 out of 103 without occipital and parietal lesion. I calculated the fragility index on this difference, and it was 2. If 2 of the 103 without a white spot in the occipital parietal lesion had a visual aura, then the association would have been non-significant. And again, recall that loss to follow-up was more than 15% in both groups, so way more than the fragility index. So the authors make positive conclusions from this very fragile data. They say, quote, transeptal puncture was not associated with visual auras. However, acute brain emboli involving the visual cortex was associated with such symptoms, and these data suggest that transeptal punctures are not causal in migraine-related visual auras, and that post-procedure acute brain emboli are apparently not always clinically silent. They then double down in their interview on Medscape. Marcus says, these findings demonstrate that contrary to a long-held belief that these post-ablation MRI-detected small brain lesions are asymptomatic, in fact, they are often referred to as asymptomatic cerebral emboli, or ACE, these small acute brain lesions actually can and perhaps often do manifest in clinical symptoms. Dr. Elias, too, is too strong. Quote, the data show that these post-ablation brain lesions are not clinically silent. He goes on to say, it may be the case that we haven't known what to look for and assessed for symptoms immediately without enough time for the subsequent visual auras that would occur. Okay, my comments again. Maybe they are correct, but the data is not statistically robust. They're making big conclusions based on 18 MRI scans, and nearly 1 in 10 patients did not have an MRI, and nearly 1 in 5 patients did not have an assessment for visual auras. Only 2 events would have changed the conclusions. The data, therefore, do not support their conclusions, in my opinion. I would conclude only that there may be a signal, but we need more data to understand the relationship of post-procedure brain emboli and visual auras. Finally, my criticism of these studies is not meant to downplay the issue of brain emboli after procedures. These are potentially quite serious because even if the effect size on cognition is small, the huge numbers of procedures being done means there could be a very large public health crisis in the future. As it is in all of medicine, everything turns on patient selection, right? When we do TAVI in an older person who has less than 6 months to live and is short of breath at rest because of their severe aortic stenosis, if he or she gets asymptomatic brain emboli, we're not going to worry too much. In contrast, when we blast a 50-year-old with persistent AFib with PFA, ablating the PVs, the posterior wall, and God knows what else, we create oodles of microbubbles in the left atrium, then, when that causes multiple brain lesions, we should worry a lot. The best way to avoid brain emboli is to avoid procedures. That's not happening now. The reverse is. Early AF ablation is a moneymaker for doctors and hospitals. And PFA lowers the threshold for doing AF ablation because it's faster and less likely to cause catastrophic complications. But our profession should be wise enough to be concerned about these observations on brain health. We should demand better data with brain MRIs as well as cognitive testing, especially with the advent of PFA. A small harm could turn into a huge problem. Okay, speaking of early treatment of AFib, the European Heart Journal has published a rapid communication from East AFnet authors. This is regarding the short-term benefit of early rhythm control versus rate control. This is listed as a rapid communication of trial results. I'm not sure whether slow or no communication would have been better in this case than rapid communication. To briefly review, New England Journal of Medicine published East AF 5 years ago in 2020. About 2,800 patients with relatively new AFib were randomized to 2 strategies, early rhythm control, mostly with antiarrhythmic drugs, versus rate control. The primary endpoint was a composite of CV death, stroke, heart failure hospitalizations, or ACS, and the 5-year trial found a 21% statistically significant reduction in the primary endpoint. The primary safety endpoint did not differ. However, the authors combined death and stroke as both primary efficacy and safety endpoints, and if you don't double count stroke and death, there were nearly 3 times more safety events, 68 versus 19 in the early rhythm control versus rate control arm. Now, a couple notables about EAST. EAST was not an ablation trial. Less than 1 in 5 patients in the early rhythm control had ablation. So you have to posit that antiarrhythmic drugs reduced heart outcomes, and that's a first for sure. Another notable thing that there was a 20% difference in the presence of sinus rhythm at 2 years. It was 80% versus 60%. So you also have to posit that a difference in sinus rhythm of only 20% drove these heart outcomes. I am pretty sure, no, I'm highly sure that the better outcomes in EAST-AF was just performance bias, in that the early rhythm control transmitted ECGs with any symptoms, and patients in that arm had many, many more interactions with their clinicians. I am not against early rhythm control, and I do it often, but I do oppose the use of the EAST-AF results to foster lucrative early AF ablations. I believe strongly that patients with AF who don't have heart failure or decompensation should be treated slowly and given a chance to let nature or natural history or risk factor modification help their AFib. One more thing about EAST-AF. When you look at the New England paper in 2020, the Kaplan-Meier curves for the primary endpoint do not separate for about 1.5 to 2 years, which is what you'd expect with patients with new AF. If there was a benefit of sinus rhythm, or if there was a benefit with enhanced medical interactions, which I think is the cause, it should take time to reduce cardiac outcomes. Now to the rapid communication of this post hoc study. Here the EAST authors look specifically at outcomes in the first 30 days, both in the overall population of EAST and in the subset with heart failure. First, result. A primary outcome event occurred in 9 of the 1,400 patients randomized to early rhythm control and in 21 of the 1,400 patients in the usual care group in the first 30 days. That hazard ratio was 0.43, and the confidence intervals came out statistically positive. The second results, deaths in the first 30 days, 1 in 1,400 early rhythm control, 4 of 1,400 in the usual care, hazard ratio 0.25, but the confidence intervals were super wide. The third result involved a heart failure subset in EAST-AF. Slightly less than a third of patients had prevalent heart failure, of which 400 were randomized to early rhythm control and 400 to usual care, and within 30 days of randomization, the primary outcome event occurred in 3 versus 14 in patients with prevalent heart failure. So this was a hazard ratio of 0.22, and again, confidence intervals made statistical significance. So the authors concluded that this exploratory analysis suggests immediate beneficial effects of early rhythm control within 30 days after randomization, including a lower incidence of the primary outcomes, fewer deaths, and a reduced composite of death or heart failure hospitalizations in both the overall population and in those who have heart failure at baseline. And this sentence, quote, "This supports its early implementation in patients at risk of heart failure or with acute and advanced heart failure." Okay, my comments. Again, I offer no malice to the authors. I'm sorry, but this is a really problematic study. The numbers are tiny. I don't care what the p-value or confidence intervals say. EAST-AF was powered to tell differences over many years with many events, not 30 days. So smaller the differences in the first year, the Kaplan-Meier curves in the original paper do not separate at all. I am not sure why the authors set out to look at a comparison with so few events, or why the European Heart Journal published something so unhelpful, but it depresses me to see stuff like this. Not only does it not help us, the small numbers of events, 9 versus 21, for instance, in a study of 3,000 patients, is more likely to deceive us. EAST-AF was a great trial. It was a great effort. Strategy trials are hard. They are noisy. Performance bias is always likely. But looking at 30 days with its small number of events only adds more noise to an already noisy piece of evidence. Finally, my friends, I'm going to close on a very positive note. A very positive note. Our government, and likely your government too, makes a lot of mistakes. So we should celebrate when our government does something smart. This month, the CMS, the main government payer in the United States, announced that reimbursement will be cut 27% for percutaneous left atrial appendage occlusion. Since I strongly believe there is little to no benefit for these procedures, perhaps even a net harm, I consider this a positive. Better would have been zero reimbursement unless the patient was in a trial, and then of course we would have an idea of whether this procedure works. Keep in mind, my friends, I will remind you that the PROTECT AF trial of warfarin versus Watchman did not pass FDA scrutiny due to internal validity issues. They said do another trial. They did Prevail. Prevail missed its first primary endpoint of stroke systemic embolism of cardiovascular death. Watchman did not meet non-inferiority versus warfarin. And most patients having left atrial appendage occlusion now would not have been included in the regulatory trials. And so no clear data exists comparing left atrial appendage occlusion to DOACs or no anticoagulation. Also, finally, a note to my enthusiastic EP colleagues. Go ahead, keep posting on Twitter that you can do left atrial appendage occlusion or AF ablation in 6.5 minutes. We get that you are fast. It's impressive. Do you think that payers don't follow you on social media? Okay, finally, I am still trying to understand the new NCD criteria for tricuspid transcatheter edge-to-edge repair. The matter in question is the coverage with evidence criteria wherein patients having TriClip have to be enrolled in a proper study. I don't know one of those yet, but I'm still continuing to searching, and if you have more information on this, please let me know and I will report on it. Until next week, this is John Mandrola from the heart.org Medscape Cardiology. Remember, if you like this podcast, please take the time, give us a rating, write us a review. If you don't agree with something I say or want to clarify, please send a message, write a comment on the website. I learned from this. Listener feedback has been a great advance for TWIC. Until next week, this is John Mandrola from the heart.org Medscape Cardiology.
You're listening to This Week in Cardiology from the heart.org, Medscape Cardiology. This podcast is intended for healthcare professionals only. Any views expressed are the presenter's own and do not necessarily reflect the views of WebMD or Medscape.